Okay, why don't we go ahead and get started? I'm sure with the rain, people are backed up, and they'll be wandering in and out. So speaking of rain, some of you guys here may realize that it was 81 years ago, just about this time of the year, was the big 37 flood, which was the last part of January and through February of that year. That I think it's not too much to say that that event pretty much remade Louisville, because the downtown was completely destroyed. The entire West End and Portland area completely destroyed, and the demographics of the city changed forever after that. My father lived here during the 37 flood and remembers the manhole covers exploding up as, I guess, gas lines burst and all that kind of stuff. My mother was in Ashland, living right on the Ohio River, and so also had the experience of the flood, but from a very, very different type of perspective. So, it's raining, there's water all over the place, but it's not the 37 flood. Don't have to worry about that. I am so pleased today to introduce our guest speaker from Duke University, Rasheed Gbadegesin. He is a pediatric nephrologist who has training initially at Ibadan, Nigeria, and then moved, after he completed his medical school and pediatrics training, moved to the States, actually moved to England first, did research training, moved to the States, and actually moved then to Duke about 10 or so years ago. He has a very active research program in the genomics of nephrotic syndrome, which is a very common pediatric nephrology entity. I'm sure that all of you who have had the pleasure of trying to learn about nephrotic syndrome realize that the way that the diseases were named were pretty much what the pathologist saw under the microscope. So, membranoproliferative, membranous, minimal change, focal sclerosis, and that's all we had. Certainly in the last 10 years, we've seen an explosion in the molecular identification of many, many different syndromes that now we know go into those single pathologic entities. And it is this that our guest speaker is going to speak about today. Please welcome him to the University of Louisville Grand Rounds.
Thank you so much for that introduction, and it's a pleasure being here. Now, so on our way here, when Dr. Leder picked me up, what the question she asked me was, have you been here before? And I said, no. But actually, as we go on with the conversation, I've actually been here indirectly, and I will tell you about that later on in the talk. So when I was invited to give this talk, and basically I was asked to give a medical grand round. It's like, okay, medical grand round. I'm a pediatrician, I'm a nephrologist, and how do you give a medical grand round? So I reflected on what I'm doing that, okay, I work on molecular genetics of nephrotic syndrome, and I thought what I can do is actually to use nephrotic syndrome as a kind of disease to actually talk about the revolution in genomics. And what I'm trying to say is that whether you're a cardiologist, a neurologist, or a pulmonologist, when we sit down in the clinic to see patients, sometimes people just come in with these results. So 23andMe, and basically said, well, we did this, and these are the things that I highlighted, and doctor, can you comment on this? So what I'll try and do today is actually trying to talk about the utility of the genetic result, the genomic result that we get in clinical practice. That's what I do for research, But what I will try and do today is actually to talk about whether this technology is actually ready for the clinical arena and when ultimately it's going to happen. The question is, are we ready to embrace it now? If you have it, what can you do with it? So that is that's how the talk is going to be. So this is the most important slide to say that I have no conflict of interest associated with this talk. Okay, so in the next 40 minutes, what I will do is I will describe briefly the epidemiology of focal segmental glomerulosclerosis, which is the most common form of nephrotic syndrome that actually predisposes to end-stage kidney disease. Then I will talk about what has happened in understanding the genomics of nephrotic syndrome and FSGS in the last 20 to 25 years. And then I will touch on a subject. So I will talk about the utility of genetic testing in hereditary nephrotic syndrome versus idiopathic nephrotic syndrome. Because, let's face it, majority of the patients that we see in clinic are actually patients that we classified as having idiopathic nephrotic syndrome. Okay? And then I will talk about the utility of this technology in improving the care of patients and what we can do moving forward. Okay. So this is a medical grand round. So I've prepared it as a clinical grand round. So I will actually start with case scenario. So here is my case one. So this is a 13-year-old white male who presented with proteinuria that was detected when he developed hypertension and bipedal edema after a dental procedure. So this young guy, who is actually about 20 years old now, as far as he's concerned, he's been well, absolutely no problem. He had this minor dental procedure, and they basically had to give him IV fluids, and then he developed this peripheral edema, and the doctor looked like, oh, this is quite unusual. Why should you develop peripheral edema from just giving you about a liter of fluid? So they basically did a UA and found that he had 4 clusters of proteinuria, and his albumin was like 1. So serum creatinine was 0.9, and basically they sent him to us. So we looked at him. So you are a 13-year-old and you are just developing nephrotic syndrome for the first time. Now we basically decided to do a kidney biopsy, and when we did the kidney biopsy, this is what we saw. So this is the glomerulus, and you can see all this pink area. This is actually scar tissue. So our pathologist at Duke, we describe this as too much pink. Yeah. So this is too much pink. So basically, Dr. Howell called me, too much pink is not good. Okay? So that was the biopsy, and that's the electron microscopy that actually showed effacement and fusion of the podocyte process. Actually, you cannot make out the layers of the filtration barrier just looking at this electron microscopy. So we do what we know how to do best, because the clinical assumption is that some of these conditions are actually immune-mediated. So we started him on corticosteroid. He had what we call, the standard therapy, 6 weeks of daily corticosteroid, and alternate days for another 6 weeks, making a total of 3 months therapy. He did not respond, and then we moved rapidly over the course of 6 to 9 months, gave him tacrolimus and then rituximab. So the long and short of it was that 1 year later, he developed significant chronic kidney disease with an estimated GFR of 20 mL per minute per 1.73 meters squared. So my question to this audience is, will you do genetic testing in this young man? We'll see later. Okay, case 2. That one is a little bit younger. So 2-year-old boy who is 7 now, who presented with acute onset of generalized body swelling. So he came straight from his pediatrician and then came to our clinic. So we did urinalysis. He had 4 clusters of proteinuria. Albumin was like 1.2. Serum cholesterol was like 400, and serum creatinine was 0.2. So classic idiopathic nephrotic syndrome. So we started him on the standard corticosteroid therapy regime that I described earlier on. So here is the thing with him. He actually responded to therapy, and he was in remission within 2 weeks of initiating therapy. But 2 months later, after completing the 3 months therapy, he had a relapse and became resistant to corticosteroid and calcineurin inhibitors. And it's like just downhill course from there. So he developed this, he had this severe hyperalbuminemia, intractable edema, and basically rapidly developed end-stage kidney disease. We started him on peritoneal dialysis. Okay, and same disease, presented the same way. This is the light microscopy for him. So this is, if you don't have this by the side, this is actually a normal renal biopsy. So what you have is you have the widely patent, capillary loops and the, mesangial cells. Actually, if they showed you this without this, and you say that this is a normal. So, for example, this is actually a normal renal biopsy, and that's why they call it minimal change disease. In fact, what I tell residents at Duke is that just looking at the light microscopy, I actually call it no change disease. And you actually make the diagnosis, and when you do your electron microscopy and you see fusion and effacement of the podocyte food process. So the same question like in the first case, is genetic testing indicated in this boy? We'll see later. Okay, so just a brief couple of sentences about nephrotic syndrome. So it's the most common glomerular disease that we see in children. When you look at the big picture, it's not a very common condition. The prevalence in most population is probably about 16 per 100,000 children. But to me, sitting down in pediatric nephrology clinic, it's actually a common condition because I just did my, actually I left, I came here last night from my clinic, and in a clinic of, so an update clinic with 16 patients, about 6 of them actually had nephrotic syndrome. So to us, it's common. Okay, now the other thing that is unique about childhood nephrotic syndrome is when I saw that the second case, the only thing that I can put in the chat is diagnosis is nephrotic syndrome. And what I tell parents is that I will not be able to make a definitive diagnosis until about 6 weeks later. And that is actually based on what I consider the most important study that has ever been done in pediatric nephrology, the ISKDC study that was done in the 70s. So what they did in the 70s was all children coming in with nephrotic syndrome, they were trying to define the morphologic causes of nephrotic syndrome and actually do what we call these days, clinical pathologic correlates. So they biopsied all patients coming in with nephrotic syndrome. I think the studies were mainly in Europe and North America, and basically defined the histology, okay? But more importantly, what they did was that they now tried to look at the response to therapy. And what they found is, irrespective of what the biopsy showed, the most important determinant of long-term prognosis is actually response to corticosteroid. And that is the reason why we do not biopsy every children that present with nephrotic syndrome this day. So you can imagine, so we do not biopsy 80% of children that actually present with nephrotic syndrome because we know that they are going to be steroid responsive, and we know that if they're steroid responsive, they're going to do well. So that's actually what we use for classification. So we have steroid-sensitive nephrotic syndrome, which is actually responsible for 80% of all cases in children, and the pathologic correlate of that is actually minimal change disease, the histology that I showed earlier on. However, we have about 20% that will actually have steroid-resistant nephrotic syndrome, and most of these cases, what they will have is actually what we call focal segmental glomerulosclerosis. The slide that I showed earlier on, too much pink, okay? And this is more common in African Americans. For a long time, we didn't know why this is so, but Martin Pollack's group, another group that worked on genetics of nephrotic syndrome, actually gave us the reason in 2010 that it's actually a single nucleotide polymorphism that originates from Africa that is actually responsible for this disparity in incidence of chronic kidney disease. So FSGS is responsible for 5 to 20% of all cases of end-stage kidney disease, and we all know that end-stage kidney disease is not a cheap disease, and the annual estimate spent by the US government to manage patients in end-stage kidney disease is about $60 billion, and it's rising. So really understanding this condition is very important. Okay, so this is what you see on pathology. So that's too much pink. That's another too much pink. And then this is the glomerular filtration barrier. So if you look at it, I will actually show a good one later. So this is the fenestrated endothelium, this is the basement membrane, and this is the podocyte process. So this thing, when you actually look at it in detailed transmission electron microscopy, it actually looks like an octopus. So what you have here is the fusion and effacement of the podocyte food process. And this is what you will see in most cases of nephrotic syndrome, irrespective of what the morphologic findings is on light microscopy. Okay, so elegant microscopy and EM studies in the early 20th century actually identified defects in glomerular filtration barrier as being central to the pathogenesis of FSGS and other glomerular disease. And the way to look at it is that this same thing, this transmission electron microscopy is actually the same thing that I've been showing all along. So this is the normal one. So this is the fenestrated endothelium. This is the basement membrane, and these are the podocytes. So see this tiny line? This is actually a very, very complex structure. It's a very complex, signaling platform. And what has actually made us to understand how complex these lines are is actually research in molecular genomics in the last 20 to 25 years. Needless to say that the glomerular filtration barrier actually serves as a selective barrier for macromolecules based on size and charge. Okay? Now, the importance of each component of the filtration barrier in maintaining the functional integrity has been controversial. However, ultrastructural studies pointed to podocyte and its slit, points to the fact that the podocyte and its slit diaphragm is actually the most important. And Karnowski in 1974 actually published this paper where he described the slit diaphragm as a zipper-like structure. And I really find this, very remarkable. If you actually blow this up and you actually see that this area actually looked like a zip. Okay? So this was in 1974. And what he basically wrote in that paper is that we do not know what is forming this zipper-like structure. However, in 1998, Carl Tryggvason, who is on the faculty at Duke and NUS, so National University of Singapore, so we have a joint medical school with National University of Singapore, actually looked at a group of children presenting with nephrotic syndrome. So Carl Tryggvason is a Swedishan and he was working in Finland. I usually confuse the two. So identified a group of Finnish children presenting with early onset nephrotic syndrome and basically did a lot of work on these children. This was before the sequencing of the human genome. So it took him forever to get this done. But it was actually that work that actually showed that what is actually forming that zipper structure is actually nephrin. And these children actually have mutation in the gene called nephrin, which we call NPHS1. And basically, nephrin actually form this kind of homophilic interaction between itself. And that's actually the backbone of the zipper structure that I showed earlier on the electron microscopy. However, there are so many other molecules that is actually playing a role in maintaining the integrity of the zipper. And after that discovery in 1998, with the sequencing of the whole genome, everything just blew up. In fact, usually what I do is I count before each American Society of Nephrology meeting, I review the literature, count the number of genes that have been reported. And I think during Dr. Ledera's regime, I think my count was 35. And then by the time we were finishing the ASM meeting, it actually increased to 40. I think we are going to get to 60 in November. So more than 50 genes have been identified. So different genes giving the same pathologic diagnosis. And that's the same pathologic and clinical entity. And that's what this cartoon is actually trying to represent. Okay, so here is the point. Familial nephrotic syndrome is probably responsible for less than 5% of all cases of nephrotic syndrome. The utility in my world, the utility of identifying this gene is actually to understand pathogenesis better so that we can tease out pathway and actually identify novel diagnostic tests and therapeutic targets. However, if you interview most pediatric nephrologists today and ask them, like the first case, and ask them, will you do genetic testing on this child? 70% will probably tell you yes. And the question that I ask is, why? Because we know that less than 5% of all cases will actually have a genetic disease. That's number one. The second thing is, what is the point in ordering a testing that probably has sensitivity of 5%, depending on the population where you're working? So the prevalence of mutation, whether it's hereditary or sporadic, actually depends on age at onset of disease, whether you have founder mutation effect, in other words, a mutation that has been transmitted through a certain population, or whether you're actually dealing with an inbred or an outbred population. And that's actually what this study that was done when I was a fellow in Michigan. The lead author is Benoit Hinks, who is actually back in Germany now. So basically what we did was, so we're all working with Dr. Hildebrand, who is the leader in this field, really, in pediatric nephrology. So basically what we did was that we had 89 children from 80 families with nephrotic syndrome presenting in the first year of life. At that time, I think the leading causes of nephrotic syndrome were Nephrin mutation, Nephrin mutation, Podocyte mutation, WT1, and laminin beta 2. So we sequenced these children for mutation in all these genes. And in terms of ethnic distribution, 64 of these children were actually of Central European descent, and 25 children were from Turkey. Okay? So this is what we found. So age of onset of mutation, so we're talking about the first year of life. We discovered that 66.7% of this cohort actually had mutation in one of these 4 genes. However, if you split it down further, so 0 to 3 months of life, 85% of them actually have mutation in one of these genes. And remember, this is just 4 genes. So if you tell me, if I'm seeing a child presenting with nephrotic syndrome in the first 3 months of life, am I going to do genetic testing? The answer is yes. Okay? Now look at 4 to 12 months, 44.1%. And then to demonstrate the founder effect. So if you look at the coloring scheme here, so this is Nephrin, this is Podocyte, this is WT1, this is laminin beta 2. These are children of Central European descent, and these are Turkish children. So what is obvious here is you have more Podocyte mutation in the Central European group. And that's why, and that's just because you have a founder mutation that changes the arginine residue to glutamine. I think it's arginine residue 130 to glutamine in Europeans. And that's actually what is driving most of the cases in European. But that's not the case in the Turkish group. So the founder effect is actually very important. Okay, so to make it more generalized, so this is a study that was actually done by Hildebrand Group. Basically what they did was actually to perform mutation analysis in 27 genes in about 1,700 families with nephrotic syndrome, and they basically confirmed the influence of age, population structure, and founder mutation on nephrotic syndrome. And that's what is actually shown here. As we get older, the chances that we're going to detect mutation is very, very low. This map is not very clear, at least to me, just looking from here. But essentially what it's showing is that if you look at Turkey, so this is the prevalence, 37.3%. If you look at Saudi Arabia, look at that, 45.7%. And Michigan actually did not appear clearly on the map, but the prevalence in the patient that we got from Michigan was actually about 5%. So really, it depends on where you are in terms of whether you want to do a genetic testing or not. Okay, so how about sporadic nephrotic syndrome? That's what we see in the clinic. Okay, so my daughter is a speller, okay, and she was actually the spelling bee champion for our middle school for 3 consecutive years. So all these things, what is the origin of the word, how do you split it in and whatever. So we used to do that together. So each time I see a word now, I actually try to do that. So we use the word sporadic. So the word is actually sporadic, it's of Greek origin, and basically the definition is an event that is actually happening at irregular intervals. Okay, then there is another word, idiopathic, which is actually very similar, and that's something that is arising spontaneously or from unknown cause. But this is my definition of idiopathic. It is the word that we use to conceal our ignorance of the cause of disease. So what I tell residents in the clinic is that, so when you are discussing a pathology and somebody tells you that 90% of the cases are idiopathic, what it means is we don't have a clue. Okay, so that's actually my definition of idiopathic. So this is the classic thing that you expect in familial disease generally. So you have multiple generation affected. So like here now you have 1, 2, 3, 4 generations, and based on how it's transmitted, and you can actually classify whether it is autosomal dominant, X-linked, or autosomal recessive. So sporadic cases should actually be rare. So how do we find someone who has sporadic case and actually has a mutation? And in reflecting about it, this is the way in which I look at it. So the person that is diagnosed with having idiopathic or sporadic FSGS with single gene mutation may actually have a de novo mutation. That's a mutation that is actually not transmitted, so germline mutation, and you can have that in autosomal recessive or autosomal dominant disease. Or sometimes people can actually have mutation without showing any signs, and this is actually much more common in autosomal dominant disease. So you have asymptomatic carrier, and it's actually when you are now interrogating family members that you just detected that, oh, you have this mutation, but you're fine, okay? Or this is actually very common. Family history not available, or we simply did not bother to take family history in the clinic. And that can actually happen with autosomal recessive genes and autosomal dominant genes. Okay, so essentially, single gene defects in patients with idiopathic or sporadic FSGS should not be a common event. It's difficult to identify. It is difficult to define prevalence. So the term, I think, should actually be idiopathic till proper history is taken or the gene is found. Okay? So it's therefore not surprising that most comprehensive data on sporadic FSGS actually come from large consortium studies, and I'll share some of that with you. So this is the study from a consortium in England, in Europe, called Podocyte. So what they did was actually to perform genetic screening in 1,174 patients with nephrotic syndrome. They performed mutation analysis in 17 genes and actually showed that majority of them actually have sporadic disease, and they were able to identify genetic causes in 23.6% of the patients that were screened. However, we did not have a breakdown of the number that were actually classified as familial or sporadic, in terms of distribution of the mutation. So this is from the same group, a much more refined study. Here, what they did was actually to screen, I think, about 20 panel of genes, and when they did that, they found that in their sporadic cases, 10% of them actually had pathogenic mutation, and most mutations were actually in podocin and WT1. Again, showing the founder effect of podocin mutation. Okay, so how about the US? So this is our neighbor. So this is actually a study from UNC Chapel Hill. It's a much more smaller cohort. They look at 65 patients, perform mutation analysis in podocin, trypsin6, actinin alpha-4, inverted formin 2, and PLCE1. And they found, they did not tell us whether this population had familial disease or idiopathic disease. But my suspicion is that since they are patients that they are getting from the clinic, majority of them probably have idiopathic disease. And what they found was that only 3.1% of them actually had a pathogenic mutation. Okay? So this is a study from my good friend, Matt Sampson, from the University of Michigan. So he used the Neptune cohort, and basically this is an all-comer US population, 312 participants. It was very strict with defining pathogenicity. Again, very similar to the study from UNC Chapel Hill. 2.9% of his cohort actually had mutation in, I think they screened about 25 genes. Okay? All right? Then compare this with the data from Saudi Arabia. So they looked at 49 families, looked at 9 candidate genes, and they actually found pathogenic mutation in half of their cohort. Okay? But look at this. So in patients with idiopathic or sporadic nephrotic syndrome, 36.7% of them actually had mutation. And the reason for this is that, like I said, until when you take a very detailed family history, you won't know. And the reason for this is that I bet that majority of the cases that they are calling sporadic are actually familial because of the high rates of consanguinity in that region of the world. Okay, so Martin Pollack identified mutation in INF2 in, I think that must have been 2008 or 2009, and it was amazing. I read the paper and I was like, okay, 16% of all cases of autosomal dominant FSGS, and that's quite remarkable. So I asked my tech, can we screen the over 150, 200 families that we have at Duke for this? And she basically came back to me, oh, I didn't find any. Okay, I said, that's interesting. So we went to the ASN meeting and I saw a study I saw an abstract from France that actually showed exactly the same thing. So it turned out that she basically did not define the exon boundary very well. So this gene has an hotspot mutation in exon 4. And she was calling, and I basically asked her, screen exon 4. And she was actually calling exon 2, exon 4. So that was why she returned the result to me 0%. I said, okay, show me the data. Let's see the primer that you used. And that was actually how I was able to figure it out. And then we did exactly the same thing on our cohort at Duke and actually found that 16% of them actually had mutation in INF2. Now, we were able to separate our cases into, just like the follow-up paper from Martin Pollack's group in Boston, we're able to separate our cases into sporadic and familial. And for a gene that is responsible for 16% of all cases of familial of autosomal dominant FSGS, we did not find a single case in someone that is reported as having idiopathic or sporadic FSGS. Okay, so if I summarize all this, essentially this is what we're talking about now. I'll probably put prevalence in the US population at anything between 3 to 4%. Because of the founder effect in Europe, probably about 10%, and Saudi Arabia is probably about 36%. Okay, so I think I'll show the cartoon later. So I was asked to write a review for Nature Nephrology in 2013 or 2014, and based on reviewing all this literature, I basically came up with an algorithm. Now, so the third year of medical school at Duke is actually devoted to research. So you actually have a medical student that you start working with towards the end of their second year. You help them to write a mentor-mentee grant, and then they spend a whole year in your lab. So this is the student that is actually working in my lab this year. So basically what I did was, we have this huge cohort, we have detailed history on them. Why don't we just look at, since they're like about 50 genes now, let's look at all the autosomal dominant genes there. And that was what she did. And in our cohort, 43.9% of them were actually familial, and sporadic were 56.1%. We screened for mutation in all these genes, and that is our mutation detection rate. So if you have a family, so familial, we were very permissive with our familial definition. So if you have a family history of end-stage kidney disease, we classified you as familial. So when we use that permissive definition, 39.5% of the population actually had mutation in one of these 10 genes there. Look at sporadic again, consistent, 4.1%. And so one of the things that they have to do is they have to learn how to analyze data and do statistics. And Jen was telling me, oh, I need to do statistics. I said, you don't need to do statistics. There's a big difference between 39.5% and 4%. She did her statistics anyway, and P was less than 0.0001. Okay? So this was the cartoon that, based on my review of the literature that was published in Nature Nephrology in 2013. And basically what we're seeing here is that one size fits all doesn't work when it comes to deciding on who you want to do genetic testing on. So based on what I reviewed in the literature, and that was before Jen did this study, I say that in a US population, the factors that actually predict someone is likely to have a mutation is that if you have early onset of disease, if you have positive family history of nephrotic syndrome, if you have steroid-resistant disease, or if you have syndromic. In other words, you have nephrotic syndrome and other extrarenal manifestation, and then chances are actually very high that you're likely to have a mutation. So I published this in 2013, and it's actually gratifying that we actually confirmed it this year. She's going to present it at the Pediatric Academic Society meeting in the next 2 months. Okay, so why do we bother to do all this? This will actually be obvious. Let's go back to our 2 cases now. So this is our 13-year-old with SRNS due to FSGS. That's the case that I presented earlier on. Then I was sitting in my office and I got a phone call from a grandma, and she basically, very smart woman, she basically took the proband sister for annual checkup and basically asked the pediatrician. So, the brother has nephrotic syndrome. He's not doing well. He has progressed rapidly to end-stage kidney disease. Can you do a test on her to be sure that she doesn't have nephrotic syndrome? And the PCP said, sure, we will. The problem is she did the wrong test, okay? The simplest test to do would have been to just collect the urine and dip it. But what she did was actually renal panel. So when she did renal panel, albumin came back as 1.4. And our interpretation of albumin to this grandma is, the albumin is a little bit low. It may be related to nutrition. Let's follow up things. And the grandma called me up and said, Dr. G, we've just done this, and this is what we found, and this is what the pediatrician told us. So I told her, when you are bringing Austin to clinic next week, come with the sister. So she came. We did the same thing, dip her urine, and lo and behold, she had 4 pluses of proteinuria. She had albumin of 1.2. Cholesterol was like 400. So we did a renal biopsy on her, despite the fact that she was completely asymptomatic, and she had focal segmental glomerulosclerosis. So all of a sudden, this was the pedigree that we started with, and that's our pedigree now. So all of a sudden, the idiopathic has become familiar, and that actually stressed the importance of actually taking a very good family history. Okay. All right. So it's obvious here. Are we going to do genetic testing in this family? The answer is yes, and we actually did genetic testing, and both of them actually had a compound heterozygous mutation in podocyte. Okay, so Austin progressed, and basically he was called for preemptive kidney transplant. So post-transplant, he had delayed graft function. He had some oliguria with moderate proteinuria. So the first differential diagnosis of our transplant team is actually FSGS recurrence. I won't fault them at all, because that's the most common cause of graft dysfunction in patients with FSGS. In fact, the number that is bandied around is actually about 30 to 40%. Okay? So very familiar. So they wheeled out this machine. So that's plasmapheresis machine. But we said no. And basically, we said no because we had this history. We know that this kid has a familial disease. And we know that patients with familial disease, the risk of recurrence in them is actually about 0 to 5%. It's actually closer to 0 than 5. So we did a renal biopsy. It turned out that he had severe ATN. His function improved gradually. He came off dialysis, and his last creatinine, so this slide is actually dated, his last creatinine was actually 1.2, and he's actually doing well now with no proteinuria. Okay. So let's look at case 2. So will we do genetic testing in case 2? So the answer is no and yes. The reason why I said the answer is no and or let me take it the other way. Yes and no. Yes and no because he presented at the age of 2 years and basically showed some response to immunosuppression. That's not the typical thing that you see in defects that are due to, diseases that are due to structural defects of the podocyte. Okay. However, remember that his clinical course was that he initially responded to corticosteroid therapy and then became secondarily resistant. Okay? So it turned out that when he presented the following, I think the ASN of 2015, I was actually asked to give a talk on utility of genetic testing in nephrotic syndrome, and I was doing my literature search. And I came across this paper. So this is a paper from Moin Salim's group in England. So basically what they did was that they looked at all children presenting with steroid-resistant nephrotic syndrome and found that If a child presents with nephrotic syndrome, you treat with immunosuppressive medication, you get some response initially, and subsequently the person becomes resistant. Chances that that person is actually going to have recurrence of disease following transplant is actually about 90%. And in my ward, that's actually the biomarker paper of the decade. That was how I describe it, 90%. So basically, when they call this, it's quite interesting. I was on call. So when they call this boy up for kidney transplantation, we do not do preemptive plasmapheresis at Duke. So I told the transplant surgeon that you need to put in a VAS cath. And he said, why? I said, because I know that the chances that this boy will have recurrence is about 90%. He said, but it's not 100%. I said, show me one thing in medicine that is 100%. Anyway, if you're not going to put in a VAS cath, what you need to do for me is that the moment you get the first drop of urine, I want his urine to be dipped serially. So we made a diagnosis of recurrent FSGS in this boy within 6 hours of transplant, and basically he developed ATN. We started him on plasmapheresis. He responded very well, and his creatinine is 0.6, and his urine protein creatinine ratio is 0.2. He's doing very well. So the power of that is that when you integrate things, you look at genomics, proteomics, metabolomics, and phenomics, and what I call phenomics, and that's the phenotyping. When you put everything together, you're actually likely to make, you are likely going to have the ability to be able to stratify patients and risk stratification. It's not just one cap fits all. It's FSGS, we're going to do plasmapheresis on everybody. Everybody's going to have recurrence. If you actually look at them, you can actually divide them into subsets. Okay, so we did. So the question is, in an heterogeneous US population, because this is data from Europe, will it actually be the same thing? And so we have this group that is called Midwest Pediatric Nephrology Consortium. So we did a retrospective review of all kidney transplant that was performed for steroid-resistant nephrotic syndrome over 10 years to determine the clinical predictors of FSGS recurrence. We obtained demographic data, look at the clinical course of the disease, and what we focused on is actually pattern of response to therapy. So pattern of response to therapy of the native kidney, and we also look at biopsy findings in the native kidney. And so we defined response to therapy like it happened in case 2. Primary steroid resistant is you did not respond to therapy at all. Date was you responded initially and you became resistant, which, if you actually look at the literature, is actually seen in about 10% of children presenting with nephrotic syndrome. Okay, and then what we did differently from Moin's study was actually to look at the histology of the native kidney biopsy, and we defined our primary outcome as disease recurrence and nephrotic ring proteinuria or biopsy-confirmed FSGS. And very interesting. So we are, okay, sorry about that. So we actually confirmed Moin's study. So these are the kids with late steroid-resistant nephrotic syndrome. 80.8% of them had recurrence, compared with 41.5% in people that were classified as primary steroid-resistant nephrotic syndrome. And look at genetic, 0. But more interesting is that when we now look at the initial biopsy, if they do a biopsy on you and they say the biopsy showed minimal change disease, 85.7% of them actually had recurrence. All the parameters that we looked, the other parameters that we looked at, we actually did not find any difference. And we did univariate and multivariate analysis, and both the histology in the native kidney and pattern of response actually pan out as a very, very important predictor of recurrence of kidney disease in the allograft. So that's that, and then that's the histology. Okay, so I'm not a very good artist. I'm sure John Peletta is actually going to put up a very good figure by the time we are sending this out for publication. But we believe that you can actually stratify patient with FSGS into 3 categories. So low risk of recurrence, patient with genetic nephrotic syndrome. I think the risk in those groups is actually closer to 0 than 5%. You have medium risk, patient with FSGS and patient who are actually primary steroid resistant. Risk is about 40%. Then you have very high risk, greater than 80%. Patient who had a diagnosis of MCD on their initial kidney biopsy or responded to therapy initially and then became secondarily resistant. Okay, so why are all this important? So this is case 2. I think I've described this already. He had recurrence within 12 hours of transplant, aggressive plasmapheresis within 24 hours of kidney transplant. He started making urine, and then he was initially nephrotic, but after a series of plasmapheresis, he got better. Serum creatinine was 0.6, and urine protein creatinine ratio less than 0.2. And yes, perfect kidney function 5 years down the road. Okay, so these two cases clearly illustrate the utility of omics technology to individualize therapy, and this is President Obama's definition of precision medicine, approach to disease treatment and prevention that takes into account individual variations in genes, environment, and lifestyle. In other words, so we have a population of FSGS patients. We all panic because they're going into transplant. We know about 40 to 50% of them will actually have recurrence. But you can actually stratify them, and there are some that you won't worry about. If somebody has genetic FSGS, is going for transplantation, I'm not worried. He's unlikely to have recurrence. If you have the clinical cause of our second patient, I will be worried that you're going to have recurrence. Okay? Then the other utility of this is that genetic screening can actually lead to preclinical diagnosis and prevention of CKD, common things, treatment of hypertension, management of proteinuria, diet, and it can also lead to better interpretation of clinical and pathologic findings. And so what we'll call genotype-phenotype correlation. And a good illustration of this is actually a study that we did in our cohort. So this was published in Kidney International in 2014. So I had a fellow in my lab who came to the lab, and he told me that his mission in the lab is actually to identify a new gene, and then he keeps screening all this family. He didn't find anything there. But what happened was he was actually identifying families that were referred to us with familial FSGS with what he knew clearly was actually pathogenic variant in COF4A3, COF4A4. And I was like, he was showing me this thing there. And basically what he actually would not look at it, and he would just put it aside. Until when we got a family, 3 girls with FSGS, the transmission electron microscopy is not typical upper syndrome. It's actually something that you call primary FSGS. Did the screening in them, and we actually found that they had compound heterozygous mutation in collagen 4 alpha 4. So I said, let's look at all these things. And lo and behold, when we looked at our cohort, 10% of the patients actually had pathogenic mutation in COF4A3 or COF4A4. So Andy still wasn't satisfied. He said, so what is the relevance of that? And I basically said, the relevance of that is that if you knew that these people actually had mutation in collagen 4A3 or collagen 4A4, are you going to treat them with corticosteroid? And his answer was no. I said, that is the reason why you have to put this together and then get it published in. Subsequently, after this, 5 or 6 publications actually showed exactly the same thing. So one of the big utility of genetic testing is that it actually gives us the ability to define disease better, and it will lead to better interpretation of clinical trials. Okay, and transplant. I've talked about transplant. Risk of recurrence in patients with familial FSGS is 0 to 8%. We know about the risk of APOL1 as the risk factor for FSGS in African American, and there's actually an ongoing study now that is actually looking at the effect of this common variant in African Americans on survival of kidney transplant. Of course, by doing the study, this is the most important: pathogenesis, identification of biomarkers, and identification of therapeutic target. And a very good point is actually TRPC6. Okay, so what have I been saying? Podocyte gene mutation can cause both hereditary and sporadic or idiopathic FSGS. The prevalence depends on age, the population structure, whether it's an inbred versus an outbred population. If you have found a mutation in the population, the most important thing is that no one cap fits all for genetic screening. You just have to define the genetic architecture of the population that you are working with before making a recommendation that we need genetic testing. Okay? And the valuable information that we get from this kind of test can actually inform approach to management of patient pre and post-transplant. Okay, so this is actually my first trip to Louisville, and it was through this person. Okay, so this is Michelle Wynn. So I joined Duke in 2007. I had a job. I was offered a job at the University of Michigan, but then I got a call from my director at that time, Dr. Foreman, and he said, you need to come and have a look. And basically set me up. The first person that I was meeting was actually Michelle. And Michelle, basically, she was going for a kidney biopsy, and she simply said, okay, they're trying to set things up. Took me to the cafeteria. We sat down there, discussed with her, and there's no way by which you meet and I just met her. This was like 30 minutes interview, and I made up my mind that this is what I'm going to do. So Michelle was there some years back to give a grand round on the same subject. Unfortunately, we lost Michelle prematurely in 2014. However, the legacy that she left is actually some of the things that are presented, and she made a big contribution to our field because this is the family from where she actually identified mutation in TRPC6. Most of the new generation medication for treatment of nephrotic syndrome is probably going to revolve around this molecule. So we owe Michelle a lot, and we missed her dearly. Now, Michelle was a graduate of UNC Chapel Hill, but she spent all her professional life at Duke, okay? And it's obvious from the color of her blouse that she's a fan of UNC. So when I was coming in yesterday, I was actually wondering what Michelle's reaction would have been to the game last night, considering the fact that the UNC game is actually coming up in another 4 to 5 days. And we miss Michelle dearly. She will forever remain in our memory. Okay, so what is left for me is actually to express my sincere appreciation to all the people that I've had cause to work with in the last 15 to 20 years, and none of this would have been possible without funding agencies. And I'll be more than happy to take questions. And thank you so much for asking me to come to Louisville.
Thank you, sir. Thanks for a great talk. I think that a couple of principles that are exemplified in your talk is, number one, much of what we see in medicine are syndromes.
Yes.
Are syndromes, and we call them a disease, but it's actually probably a number of diseases that just look the same. And it's only with testing such as you've described that we can actually dissect that out. So where do you see this field going in terms of trying to ramp this up for many places, bigger places, and application to other kidney diseases?
Okay, so I think what we need to do is, it's all well and good to study familial disease, single gene defects, but those things are actually responsible for a very small fraction. What I would like to see moving forward is a kind of integrated approach where we actually harness all the technology that we have, proteomics, metabolomics, genetic risk factors, and then detailed phenotyping, and actually integrate all this out to actually identify, tease out the pathways that are actually much more important to the general population. And the only way by which you can do this, so this is the other part of the talk that I like to do, is actually multidisciplinary approach to research. The days and ages where you want to do the clinical work, you want to do the genetic work, you want to do the animal modeling itself, everything together is just not efficient.
Question. Mike?
Yes, my chance?
Thank you for the excellent presentation. I have a question regarding the spontaneous mutation.
Yes.
And when you do your genetic testing, are you doing this remotely, like salivary DNA, blood DNA, or are you actually using tissue in the lab?
So we're actually using blood DNA.
Could there be any chance where there are de novo mutations in the glomerular cells that are not present in the network?
Precisely, yes. So that's quite possible. And that's why I said that what we need to actually define this very well and identify pathways that are very important to the general population is actually an integrated approach. You look at genomic samples, you look at tissue samples, you do proteomics, you do metabolomics, and then integrate it together and actually see where you have convergence.
Steve?
So many of these genes are structural and others are involved in cell-to-cell communication.
Yes.
Many I didn't recognize. So is the expression limited to the kidney, or is there extra renal expression of, and what kind of phenotype results from a genomic mutation that's in other tissues?
Fantastic question. So most of these genes are actually structural. So two of them that I know are hardly expressed in other tissue is actually podocyte mutation and Nephrin mutation. Now, the other genes, TRPC6, INF2, aniline, they actually express widely. And for most of the autosomal dominant condition, really, most of them actually do not have extrarenal manifestation. I think what we're actually looking at is the milieu within the kidney. So there are some other gene-gene interaction and that is actually resulting in renal phenotyping that, for example, may not be present in the heart or the lungs, despite the fact that the gene is actually expressed widely there.
Yes.
So practically, the steroid responsive disease, and there's everybody else who will eventually get a transplant. Is there any idea that any of these could possibly be targeted with any sort of therapy short of transplant? Like the age of CRISPR, is there any idea that that might be used?
Yes, absolutely. The answer is yes. There are some other technology other things that are actually possible, from technology. For example, let me give you an example talking about, other targeted therapy. So APOL1 variant is common in African American population. Actually, from my part of Nigeria, I'm from southwestern Nigeria, the prevalence of the APOL1 variant is about 13%. Okay, and if you look at the population of patients with CKD, probably about 25%. Now, it turned out that, at least as of now, from a report from India, APOL1 is actually functionally redundant. So, really, if you target, so this is something that is causing majority of the chronic kidney disease among African American population. So, if you do gene editing, all right, that may actually be the solution rather than actually looking for a target. But we have to individualize it. It depends on what the gene is and what it does. Yeah, so that's my response to that.
Okay, thank you. For all of our guests from out of town, Louisville is the home of the Louisville Slugger.
Wow.
And so we present you with this Louisville Slugger with your name, Medicine Grand Rounds, University of Louisville, February 22nd, 2018.
Wow. Thank you
You may
so
take it home
much.
and use it on your medical sheet.
Thank you so much. Thank you. Really appreciate it. Thank you for asking me to come.
It was great. It was wonderful. So this guy is going to come down and take a picture of us,
Okay.
with your Louisville.